Good morning, good afternoon, everyone. My name is Chris Duncombe. I'm the Chief Medical Officer at the International Association of Providers of AIDS Care in Washington, DC. Welcome to this panel, which is part of a series of presentations in the COVID in the Americas virtual conference, hosted by AIDS Healthcare Foundation, Global Public Health Institute, and the Institute of Advanced Study of the Americas at the University of Miami, and co-hosted by IAPAC. The topic for today is health service delivery in a pandemic, maintaining continuity of care. I would like to take this opportunity to first introduce our two panelists for today. Dr. Amanda Castel is a tenured professor in the Department of Epidemiology at the George Washington University Milken Institute School of Public Health. Dr. Castel's expertise is in using public health surveillance data to monitor progress along the HIV care continuum, and she runs a large longitudinal cohort study of over 11,000 people living with HIV in Washington, DC, the DC cohort. Dr. Castel is a board-certified pediatrician and leads the DC Center for AIDS Research Ending the Epidemic Scientific Working Group. She is a member of the DSMB for the National Institutes of Health Institute for Drug Abuse Clinical Trials Network, and Amanda also serves on the Board of Trustees for our organization, IAPAC. Thanks very much for your time today, Amanda. Dr. Pedro Cahn is the Scientific Director of Fundación Huésped in Buenos Aires, Argentina. He's a senior consultant in infectious diseases at the Hospital Fernandez in Buenos Aires and a past president of the International AIDS Society. Dr. Cahn is an external advisor for WHO, UNAIDS, PAHO, and for Médecins Sans Frontières. He has more than 200 peer-reviewed publications. Welcome to you both. So just to set the stage for today's panel, I think like some of you, like many of you, I've been attending the virtual CROI conference this week, which interestingly was kind of half devoted to HIV and half devoted to COVID, to SARS-CoV-2. There are a lot of interesting sessions on the interruption of health service delivery, both in the US and in sub-Saharan Africa, and some discussion on mitigation strategies. Just brief, these are a couple of things that caught my attention. There was a nice presentation from CDC on pediatric and adolescent HIV testing and diagnosis in the context of COVID-19. Data were presented from 14 PEPFAR-supported countries in sub-Saharan Africa. New pediatric HIV diagnosis declined by 28% from 2020 compared to 2019. Adolescent new HIV diagnosis declined by 17% during lockdowns. A few countries like Cameroon, DRC, Cote d'Ivoire, Nigeria actually reported maintaining their testing levels or even increasing them, largely due to a scale-up of community-based testing, including self-testing. In the US, state of Oregon, public health sector testing for HIV and STIs declined dramatically during that state's stay-at-home order. For example, new syphilis diagnoses were down 45%. The good news is that testing rebounded very quickly when the stay-at-home order was lifted. This wasn't from CROI, but I thought it was interesting that Marta Bafito and colleagues from Chelsea Westminster Hospital in London recently published a letter to the editor of Clinical Infectious Diseases, in which they report an increase in admissions to their hospital among people living with HIV, with advanced HIV diagnosis in 2020 compared to 2019. In 2019, 26.5% of admissions were due to an AIDS-defining condition. This increased to 52%, almost double, in 2020. Probably reflecting the difficulty of people accessing care or the reluctance of people to go out because of fear of being infected. As part of this panelist to talk about mitigation as well, not just disruption. So we'll talk a little bit about telemedicine later, but there was an interesting article in the Journal of Addiction Medicine last month, which reported on a program in New York City, which piloted telemedicine-based opioid substitution therapy with unobserved home-based OST. 78 people initiated opioid substitution therapy for the first time, totally remotely, and completed 252 telemedicine visits. So I think one of the things that this pandemic has taught us is that there are ways to mitigate the disruption to services, including through telehealth and telemedicine. So let me turn it over now to our panelists. So perhaps I could ask Dr. Castel, ask Amanda, could you talk a little bit about your experience as a treating physician in Washington, DC, and a person who's been managing the large cohort, the large DC cohort over the past year? And I think we mentioned earlier that yesterday or today is actually 1 year since all this started. So Amanda, I'll hand it over to you.
Thanks, Chris, and thank you for the invitation to participate in this discussion. You know, I think that just to start off with, this has clearly been an unprecedented situation and unprecedented disruptions. And it's fair to say that I don't think that any of us were necessarily prepared for these types of disruptions. If you think about it, there are approximately 1 million people in the United States living with HIV that needed care and treatment, and millions more who needed preventive services like STI testing, HIV testing, and access to PrEP. And we know that with respect to prevention, that there were significant disruptions in services, but yet these high-risk behaviors continued. There have been quite a few papers and analyses, some of which you alluded to in your introduction, around this kind of service disruption with respect to prevention services. There was a nice paper by Travis Sanchez and colleagues early on. They did an online study of men who had sex with men who were living in the South who were trying to access preventive services. And actually early on noticed that there was actually no change in access to preventive services. This was done in April of 2020, but we see that as the pandemic has persisted, that there clearly have been disruptions in service access, and these high-risk behaviors continue. There's a nice study from McBride and colleagues that was conducted in Wisconsin, which found that while school closures had resulted in significant declines in respiratory illnesses, such as acute otitis media and strep pharyngitis, they actually observed an increase in gonorrhea cases among middle and high school students. And you also alluded to the paper that was presented at CROI earlier this week about the disruption in public sector HIV and STI testing in Oregon. And similarly, in San Francisco, there was a paper presented as well that showed that HIV testing, viral load testing, and PrEP engagement had declined significantly and have still not rebounded back to pre-pandemic levels. So we know that, you know, these are all just examples of that disruption and prevention. With respect to care and treatment, you know, in preparation for this discussion, I did an informal survey of some of my colleagues at large clinical centers in the US, including in Cleveland, Miami, Atlanta, and Birmingham. And I think several themes arose that were consistent with our experience here in DC. All of those sites have pivoted quickly when the pandemic started to be able to figure out how to continue to provide care. Luckily, there were no complete closures, but there was certainly a sense that we needed to start triaging patients, right? Only having those patients perhaps who were not virally suppressed or who had opportunistic illnesses or who were high acuity, to make sure that those individuals were able to continue their care. And that, you know, we had to be somewhat flexible about their ability to obtain labs during this time, particularly in some instances where just the lab itself, the physical space, is very small. As we've seen, telehealth became kind of the mainstay and main mode of care delivery during this last year. Many state and local health departments have been able to change their regulations to allow for it. Many patients actually didn't want to come in, right, because they were worried about potential exposures. And so we gave them the options as to whether or not they wanted to have in-person visits or telehealth visits. In speaking with providers, again, throughout the US and as well as the providers in DC, you know, many people had issues with transitioning. Many patients had issues with this transition. It was certainly harder for older patients to figure out how to use these different platforms. A lot of visits were by phone initially, which of course doesn't allow for you to do any visual assessment. Interestingly, a colleague in Miami noted that they had informally surveyed their Ryan White clients who have been able to do telehealth visits. And even though they've been successful, 90% of their patients reported wanting to ensure that in-person visits resume post-pandemic. So although telehealth works, we know that for some people it is not going to be the solution and the long-term solution for care delivery going forward. Also of note, I think, is how we were able to pivot with respect to providing some ancillary services and focusing on some of these special populations around HIV, right? So, for example, people who were Rapid Start clients were prioritized to be able to come in for in-person visits. All of the paperwork that needs to occur when you start somebody on antiretroviral therapy was able to be done remotely in some situations so that you could really focus on that in-person clinical visit while they were in front of you and hopefully get them in and out of the clinic rapidly. Mental health also, we know, is a really important service that we need to continue to provide to people with HIV. And that also was prioritized in many settings, as well as substance use. So you mentioned the program that New York City developed around these mobile methadone clinics. But again, even in some places, for example, Miami, they already had a teleharm reduction program that they were able to basically incorporate not only their HIV, Hep C, and naloxone distribution, but also incorporate COVID testing into that as well. And then lastly, you know, here in DC, our health department was also very nimble. They developed and made available at-home and walk-in HIV and STD testing. They developed an express clinic for self-collected specimens at their health and wellness clinic. And they also are launching a teleprep program where individuals will be able to get PrEP online, and they will do self-collection of labs. And then finally, the DC cohort, which you mentioned before, is a longitudinal cohort of people, about 11,000 patients living with HIV, getting care at 15 clinical sites in DC. And we've been able to look at our utilization data between March and June of last year and compare 2019 and compare it to those data of 2020. And interestingly, we've actually seen a significant increase in the number of encounters. And so when we delved into that a little bit more, it is related to these telehealth visits that we know are allowing more people to access care, whereas perhaps, you know, we may have had patients who were out of care previously, but the telehealth has enabled them to be able to engage with us. We have seen, though, declines in HIV RNA testing. And we also surveyed our patients in the cohort to understand some of the impacts of the pandemic on them. 91% of them still have received some type of HIV care during the pandemic period, which is amazing. We, you know, asked them how they've been able to reach their providers. 47% have been able to do it by phone. Another 45% have been able to do it by video on their telephones, and about 22% have been able to have a video visit, and 80% of them report being satisfied with telehealth. So, you know, I think these are all examples of how providers throughout the US have really been nimble, flexible, and have been able to adapt to the changing needs of the pandemic. And it will be interesting to see going forward how and whether some of these changes persist post-pandemic.
You're muted, Chris.
Sorry, got me again. It's one thing we'll all remember after this is the mute button, I guess. Yeah, thanks. I mean, we discussed a couple of days ago, sort of rehearsing for this, that it's really been a two-way street, and even though the disruptions are real, and that it's led to changes that's in some ways have been good changes, and we'll talk a little bit more later of how we might think those changes might persist after the pandemic. Pedro, could I ask you to talk a little bit about your experiences in Buenos Aires, what the pandemic has looked like in your city, and how it's affected the way that you've been interacting with patients?
Of course, Chris. First of all, let me thank the organizers, IAPAC in particular, for inviting me to be part of this interesting session. I would like to give you a little bit of context of what happened worldwide. I think that the best definition that we can find is from the World Bank, that called the disruption of services the killer number 2 in this pandemic. Killer number 1 being COVID-19, obviously. Killer number 2, disruption of services. And as we learned from The Economist, in the market usually everything is about supply and demand. And in this case, we had shortages in supply, but also shortages in demand. People not coming to the services, as Amanda pointed out. There is a survey from the WHO that showed about 90% of the countries that responded to the questionnaire reported some level of disruption of services. In the Americas, the Pan American Health Organization did so, and among 18 countries that responded, 64% reported disruptions. And these disruptions were different for different type of services. For instance, for non-communicable diseases was about 70%, for family planning and contraception, 65%, cancer services, 55%. I still recall a paper that was published about July last year in Lancet, in which the oncology demand in the UK was dropped by 50%. So in the first consultation for an oncologist drops 50%, that means late diagnosis of cancer and with the immediate consequences that you can imagine. And regarding HIV, the numbers in the Americas were 32% reduction in the disponibility of services. So, and here we need to put into the equation also not only the proportion of services that were in some way harmed by the COVID-19 pandemic, but also how long did it take? Because it's not the same if initially during March and April you blocked the services, or this was in some way blocking the services for many more months. For instance, there is a model that was developed by the World Bank, telling us that if you reduce 15% the mother and child services for 6 months, this would mean worldwide more than 200,000 child deaths that could be avoided, and more than 15,000 maternal deaths. So this is just to put it in context. What happened in Buenos Aires? In Buenos Aires, as you know, we are now in summer, so we are in the southern hemisphere. So we could see what was coming to us, looking at China, looking at Europe, looking at the US. So we had enough time to prepare our healthcare system, to increase the number of intensive care bed units, to increase the number of mechanical ventilators, to train more people to manage this type of tools, etc. So this avoided the extra death that could be avoided, because if we wouldn't have prepared our system as we did, the situation would have been much worse. Now we are in summer. We have about 5,000 to 7,000 cases a day, still high, but it's about 50% of what we had in winter. We are expecting a second wave. And what we saw in terms of services was also a disruption that I go on to describe in a few minutes. So first of all, what we saw in regards to HIV is that people didn't come to our services in general because they were afraid to move around, as Amanda pointed out. Second, infectious diseases physicians, which are mostly taking care of HIV patients, were very busy taking care of COVID-19 patients, special wards, new beds to be taken care of, etc. The burden of work was tremendous for everybody, but particularly for infectious disease physicians and nurses. So again, the supply and demand issue came across. What we did, for instance, in my hospital, we put up a system in which those healthcare workers that couldn't assist patients because they were older than 60 or they have some comorbidities, etc., were put in charge of the telehealth medicine, working as it follows. We use the WhatsApp video call in order to have a face-to-face meeting with people needing consultation. We proactively did so. We didn't expect that people called, so there was a list, and people were called and asked for a remote consultation, which is good. But I think, if you allow me, I would like to do a comparison. Looking at the travel channel is fantastic, but traveling in real life is much better. And this also applies for medicine. We need to understand that we are in a pandemic, in an extremely difficult situation, that we are trying to cope with these challenges, but it's never the same as having the face-to-face meeting with the patient, in which we have different type of contact. This will come back, I'm pretty sure. Vaccination, if the vaccination expands quick enough, and I know we will come back to our face-to-face consultation. But meanwhile, this is the second best we can do. Let me tell you about some interesting experiences that we have in this country. For instance, in the Cordoba province, which is a large province in about 700 kilometers north from Buenos Aires. In this province, what they did is they have different facilities to test for COVID-19. But what they did is to offer people that come voluntarily to be tested for COVID-19 to also be tested for syphilis and HIV. And guess what? They found 3% of people with RPR positive for syphilis, and almost 0.5%, which is around the national prevalence for HIV, for HIV positive people. So this was a creative way in which you could take advantage of people coming spontaneously to be tested for SARS-CoV-2, and they were offered, and more than 85% of the people agreed and accepted to be tested for syphilis and HIV. So in some way, there are creative manners to really address this type of challenges. I think that we are now not at the end of the epidemic. I think everybody would agree that we have still a long way to go, and we need to readapt our systems in order to provide care not only for people living with HIV, but also people with other chronic diseases like diabetes, people that are with anticoagulation services, oncologic patients with chronic autoimmune disease, etc. They need to be controlled, and we need to be creative. As much as we can, we need to do it in person, as much as it's possible, and it's highly dependent on the level of lockdown that you have in your city or in your country. But the second best would be telehealth. But in some way, we need to plan ahead in order to leave nobody behind, regardless of if this person has COVID-19 or not, because it's obviously our priority to address the COVID-19 pandemic. But we need to keep in mind that there are millions of patients that are requiring our medical services, and we need to serve them as well. So just to round up, I can tell you that the pandemic has affected severely the situation in my country. In the region, we have really a mosaic. We have a complete disaster in countries like Brazil due to the really stupid policy promoted by the federal government in Brazil. They are now in a very, very dangerous situation with about 95% of the intensive care units beds occupied, people running out of oxygen, etc. And this is because the federal government didn't have a policy in this regard. Other countries were strong in this point and are much better off. But in all countries, the general services were affected. So we need to work finding with creativity the best way to address both needs: the need of people with COVID and the need of people without COVID, but with other diseases that also deserve to be assisted in the most efficient and professional way. Thank you.
Thanks, Pedro. Yeah, that's very interesting to hear. People on the line, there's a chat box. If you do have any questions for the panelists, please feel free to enter those into the chat box. Amanda, you mentioned that telehealth, telemedicine was found to be quite acceptable by your patients. What was your personal experience of telehealth? How did you feel about consulting with somebody over WhatsApp or Zoom?
Chris, I actually haven't done telehealth visits. So when the pandemic started here in DC, I'm trained also in applied epi and outbreak investigation. And so I actually put my clinical practice on hold and was doing case investigations with the health department initially. But what they were doing, I guess that in a sense, it almost ended up being telehealth itself. But in order to quarantine and monitor people who were in quarantine and isolation, those were telehealth type visits. So, we were able to deploy some people out to people's homes who needed additional care, who maybe needed to be triaged and sent to the hospitals. But we were able to monitor them also remotely through telehealth. And I think that it's been an effective program. I just find it fascinating. I think, for example, the Miami data that I shared, that 90% of those individuals want to come back to in-person visits, despite them finding telehealth to be satisfactory. And so, we have such a diversity of clients and their needs, their mobility and their ability to be flexible and either leave their homes or leave work, depending on where they live, how far they have to go to get from their homes to the clinic. Certainly we have people living in rural areas where telehealth might, really be something that stays much longer than after the pandemic as an effective way to deliver care. So it may become one of those elements of differentiated care depending on that patient and their particular needs. I do also want to just mention one thing that we didn't talk about is we didn't really talk about the healthcare workers themselves and the clinics. So, in our experience in DC early on, we did have some clinics who had healthcare workers who had COVID and had to close down temporarily in order to address that. And also, again, as we note that we are now a year into this, this is having a toll not only on our patients, but also on the providers themselves, and particularly those of us that focus on infectious diseases. I think that, we'll have to see what the long-term toll is in terms of our ability to be resilient and to continue to provide care effectively.
Yeah, thank you. Pedro, did you have any other comments or suggestions about telehealth and telemedicine from your experience?
Yes, I had the opportunity to do a couple of consultations, more than a couple, in telehealth, and it works. It's much better than doing it over the phone. You can see the face of your patient, the patient can see your face, because the non-verbal language is very important in patient medical interplay. No? But again, as I said, it's good. It's the best that we can provide in certain circumstances, but it's not a full 100% replacement for the in-person consultation. No? My experience is that, for instance, I had consultations with patients that couldn't travel because they live in other cities and they were maybe 100 or 200 kilometers away from my city, Buenos Aires, or people that were too sick in order to move around, or just they were afraid, and they asked me for remote consultations. But that I did. I prefer to do Zoom or one of those platforms because it's more flexible than just talking over the phone. But I think that it's a good practice. We need to learn to do it. We need to give people time. Not all our patients are completely skilled to use these platforms. Sometimes we need to teach them. You have to do this and that. You have to open this and that. Most of the patients know how to manage it. It's easier when you use WhatsApp video calls, because I would say 95%, or if not 99% of our patients have a smartphone, so they are used to use it. But when it comes to other type of platforms like Webex or Zoom, etc., it's more difficult for some of them. But anyway, it's a good thing to have. I just want to challenge you, and for 1 minute, imagine that this epidemic came 20 years ago, not 100 years ago, 20 years ago, without all these platforms. What would have we done? How could we cope with the needs of our patients that were impossible for them to come to the clinics, or our clinics were just devoted to assist COVID-19? And following on Amanda's comments, let me tell you that in our country, we also had a lot of healthcare workers that were affected by COVID-19, and we had almost 100 or more that passed away due to COVID-19. So it's this is a heavy burden. The psychological burden for our healthcare workers is tremendous. I know that many of my colleagues, they moved out from their houses in order not to come back from the hospital to their homes, because they live with their mother or grandmother or so, or they have kids, young kids, etc., that they don't want to come back in this situation. So it has been tremendous for our healthcare workers, and we need to really pay our full respect to all people that are working in first line, because it has been tremendous for them.
Yeah, I think one of the things that strikes me is that, Zoom is, I mean, there are many platforms, but Zoom is just so easy to use, and everybody now can use it, and it's kind of free for most people. It's really made a difference. And as you said, Pedro, if this happened 20 years ago, before we had widespread access to internet and to platforms like Zoom, it would have been a very different story. That's for sure. But I think, I mean, as Amanda said, that, patients would, once this is all over, they would rather go back to in-person care. And I think, as you said, Pedro, we would all rather go to a CROI conference or an IAS conference in person, where we can meet people and say hello and all of that. Conferences are really, it's part of how we all learn. It's part of our lives. It's part of being part of the HIV world for the 30 years that all of us have been doing this. And to have to do it at home is like, it's okay, but let's hope as soon as we can travel, we're all going to travel, I'm sure. Yeah.
Chris, the best part of the conference happens in the corridors.
Exactly, Pedro. It's right. That's what it's all about. That's where you network. That's where you meet people. That's where you design new studies. That's where you talk to sponsors to get some funds to do your work. All of those. All of those things over Zoom is it's not the same. Could I ask you both, other than telehealth and telemedicine, what other kind of interventions have you seen that have been effective in mitigating service interruptions? Anything stuck in your mind?
Well, what I saw in my country is that maybe the first case of COVID-19 was diagnosed here on March 2nd last year, but maybe in July or August, the government started to promote people to come back to the hospitals, and if you have a chronic disease that needs control, ask your doctor, try to contact him, etc., etc. I think it was a little bit late. It should have been probably before that. But I think it's very important that the healthcare authorities send a clear message to the population. It's safe to come back to the hospitals if you use a mask, if you respect social distancing, etc. Wash your hands, blah blah blah, all the things that we know. But don't refrain to do it, because it's very important to be controlled. I think that we are seeing now probably the outbreaks of several diseases. For instance, what was mentioned in terms of what you mentioned, Chris, that happened I think it was in Chelsea, Westminster, that the doubling of hospitalizations in HIV patients because of severe advanced disease. Well, we are seeing something similar. We are seeing a lot of new diagnoses now that were down during 2020. Surprisingly, the quote unquote, the HIV epidemic was stopped in in Argentina in 2020 because the number of new HIV infection diagnosed went down. But this is fake. This was just a result of the lowering of the number of HIV tests done that was down for about 20 to 25%. We will see the consequences of this year, next year, the year to come, etc.
Yeah, I agree with you 100%, Pedro. I mean, we're going to see, you know, late syphilis diagnoses probably go up. You know, when you think about people with HIV, and at least in DC, the proportion of people that have 1, 2, 3 comorbidities in addition to their HIV disease, you know, how well have those comorbidities been controlled, right? Because we're speaking from the perspective of people focusing on their HIV, but we don't know how well their diabetes or their heart disease or things that maybe they didn't see as urgently needing care during this time period were addressed. And so it will be interesting once we kind of get out of this acute phase of the pandemic to see, you know, how people are faring long term. To your question, Chris, I think one of the other interesting things, and Pedro alluded to this before, is the co-location or the kind of packaging of testing, right? So if you're focusing on COVID, you can also focus on other testing at the same time. And also with individuals who do have COVID, understanding that it's not just caring for their COVID or their SARS-CoV-2 infection, but also making sure that they have the wraparound services that they need, which is something that we often do with HIV care. And it's good to see that it's happening with COVID-19, right? So making sure that people have access to housing, that they have, you know, here we have a lot of rental support services. Right now we're giving our patients groceries at the pediatric clinic because we know there's a lot of food insecurity. So making sure that they have all of those different supports is really important as well, not only for those living with HIV, but also just in the context of COVID. And there's so many disruptions socioeconomically in people's lives that we really need to make sure that we're addressing all of their needs.
Yes, following on Amanda's comment, I think we need to highlight the issue that we know from a long time ago, that poverty make the epidemics worse, and epidemics makes poverty worse. And of course, it's not the same situation if you're a middle-class citizen with a private insurance, at least in Argentina. It's not the same situation as if you're poor and you live in a district that is far away from a hospital, etc. Your chances to get good medicine will be different, and this is only aggravated by the pandemic. So it's very important to take in account that social disparity, social injustice is one of the main drivers of the epidemic, and COVID-19 is not the exception.
Indeed, it's shocking to me in the United States to look at, you know, yesterday from Croy, that black people in the US who get COVID are 9 times more likely to die than white people. It's just so striking. You know, it really is. And, this is a country which is supposed to have equality. It just doesn't, and you can see how countries in Africa also. Anyway, so I mean, one of the good things, I think, is the impact on service delivery and differentiated service delivery, because, you know, despite WHO saying that countries in sub-Saharan Africa should have multi-month dispensing and visit spacing, in a lot of places it wasn't happening. It's been forced to happen. So I think that's a good thing. People are now being able to get 6 months supply of their drugs, and supply chains are being able to adjust because they just have to, you know. So I think with HIV, we talk a lot about self-management and the importance of people sort of taking on self-care as part of their management. Do you have any comments or thoughts about how your patients might have increasingly been able to manage their own conditions because they weren't able to see a doctor?
Well, you know, Chris, there's not such thing as a typical patient. We have different types of patients. If you're talking about the characteristic patients, middle class, NSM, that has been undetectable for the last 12 years with fantastic CD4 counts, viral loads below 50 forever, and this typical patient that comes to you and you ask him, how are you taking your medicines? Oh, doctor, don't get mad on me. You know, last Wednesday, instead of taking my pill at 9 o'clock, I did it at 10 p.m., but I promise it will never happen again. So this is the non-adherent patient for in one edge. In the other edge is the patient that is difficult to treat because he has other comorbidities, the patient that has substance abuse, the adolescent patients. There are certain type of patients that need very, very close follow-up, and we cannot rely on self-management. So most of the patients in my clinic, they are able to do self-management and to be interviewed via telehealth every 6 months, every 4 months, or whatever. But there is a subset of patients in which you cannot do that because this is a recipe for failure.
Indeed. Amanda, any thoughts on changes in the way that your patients have perceived their ability to self-manage or not?
Yeah, no, it's interesting because the clinical practice I do with HIV is in a pediatric and adolescent context. And so, you know, these are very different than the adult individuals that are being cared for in other contexts. And so, you know, oftentimes what we're seeing is the impact on their parents or their guardians, right? And their ability to kind of navigate all of these systems and changes during the pandemic, and how that kind of can trickle down to the children and the impact that it has on the kids or adolescents. So, you know, it's sometimes not the patient, that him or herself, that's in control of that situation, but that adult or parent or guardian. It's been interesting. A lot of, or I should say anecdotally, we've seen quite a few patients now who are asking for multi-month dispensing. And I'm not sure if it's related to the pandemic or not, but many are now saying, you know, are you sure you can't get me 60 or 90 days supply of medication versus where, you know, we might have given them a 1 month supply with refills before. So that's just, you know, anecdotally something that I've noted has changed a little bit.
This is sort of not really about service delivery so much, but you know, I think that if you look at the literature of whether people living with HIV are in fact more susceptible to COVID or not, and whether in fact they have worse outcomes or not, and whether in fact they're more likely to die or not. I wonder if you had any thoughts about, from your experience, do you think people living with HIV are more severely impacted by this epidemic or not?
I don't, from a clinical standpoint, the data sure look like their risk is similar to that of the general population, assuming that they are on antiretrovirals and that they are, you know, immunologically stable. From a social determinants of health and a health disparity standpoint, you know, we know that, at least in the US, that it is those, you know, under-resourced areas, those racial ethnic groups that are disproportionately impacted by COVID. And so, as I alluded to earlier in this discussion, that, you know, it's really all of those other issues that make the pandemic more difficult for individuals living with HIV, maybe not from a clinical risk standpoint, but that they are at risk in other ways around the social determinants of health.
Yeah, I fully agree with Amanda. It's not HIV that makes you more prone to get COVID or to have severe forms of COVID, but it's your social condition and also the number of comorbidities. When you compare a population in the same age, let's say from 30 to 50 years, and you look at the number of comorbidities that the HIV negative population has compared to the HIV positive one, you will see more comorbidity among people living with HIV. So it's the issue of comorbidities and the social situation that is usually associated in many cases with the HIV infection that drives you to have more risk. I fully agree that a patient with a decent number of CD4, whatever cutoff you would like to take, 350, 500 or so, and upward, no? They are not at higher risk of contracting HIV. There's no evidence for that. And even if some papers showed that among people with HIV, there were more trend to have severe forms, this needs to be very carefully looked at, because you have to correct for comorbidities and for other situations. So, and this is an interesting point to discuss. If you read the 26th of February paper from NIH about recommendations for people living with HIV and COVID, they say that people with HIV needs to be prioritized to be vaccinated, which is in certain way in a contrast with the argument that we are doing, that it's not HIV what drives you to that situation, but it's the particular situation of living with HIV that drives you to that way. And prioritization in vaccination is a biological, epidemiological, and ethical problem that we need to be addressed very carefully.
Yeah, you know, we looked at our DC cohort data, and we looked at all of the comorbid conditions that would put someone at risk, higher risk for severe COVID infection. You know, 45 to 50% of our population is obese. 30% have hypertension. You know, if you just look at all of these, cardiovascular disease, kidney disease, highly prevalent in our population. Even though our population is primarily virally suppressed, it's those comorbidities that put them at higher risk for severe COVID infection. And now we're starting to talk about that in the context of vaccination, right? And so that these really do need to be priority populations for vaccination. Again, maybe I think what you were saying, Pedro, is not because of their HIV disease, which might be controlled, but because of all of those other risk factors.
Agree.
Yeah, I think so. And I mean, you know, if you look at data from the UK, the Open Safety database, which showed a twofold increase in death amongst people living with HIV, and also the one from the Western Cape. I fully agree that it's the comorbidities and the social determinants of health that are driving the worst outcomes in people living with HIV, not HIV itself. Still, there were data presented at CROI that said differently. So I think the debate is still ongoing. And if you look at states in the US, some states are prioritizing people with HIV for vaccination, some are not. CDC is not really saying anything. So it's kind of it's still one of those situations where the data are evolving. So. Can I ask, what time is it now? We've got another 10 minutes. What do you think after the pandemic that you would like to see maintained, or some of the things that have been forced on us as part of the pandemic that you feel have actually been good things that you would like to see maintained going forward in terms of service delivery?
So while I haven't personally used telehealth with my patients yet, I do see the benefits of doing it. And not only just for their care delivery for HIV, but also for mental health services as well. I think that it's just really critical, and it's maybe a lower barrier to be able to meet that retention and care, you know, kind of definition or need for some of our patients, and allows more flexibility for those that, you know, that have other competing priorities in life and make it difficult for them to actually get to their visits physically. But this might be a good alternative solution to supporting them.
Well, in my case, I can tell you that, for instance, for prescribing medicines or prescribing a CT scan or an NMR or whatever, used to be cumbersome paperwork. You have to fulfill forms and sign and stamp, etc., etc. And suddenly, the pandemic came across, and now you can do it at home with just doing your prescription, take a photograph and send it by phone, and guess what? The patient gets the NMR, gets the CT scanner, gets the... So if this could happen during the pandemic, why couldn't it happen afterwards? I mean, before that, it was impossible. You missed the stamp. You missed the one number in the social security number. No, the procedure cannot be done because this is wrong. And now you can do it over the phone with a photograph taken with your smartphone. So I think that this is one of the things that could help us to think about to tremendous bureaucracy that our patients, at least in my country, sometimes have to pass in order to get their services that they deserve.
I think a lot of it's about this. We talk a lot about lowering the barriers to care. Still, wherever you live, whether it's in Africa or in the US or South America, there are still significant barriers to care that stop people accessing. And anything that you can do to lower the barriers, like the paperwork, not making people go to the pharmacy every month to get their drugs, giving them enough supply so they don't have to make that trip. It may seem like a simple thing to go to the pharmacy, but for some people it's challenging because they can't afford the bus, or they don't have a car, or they're working long hours, they've got kids to look after. All these things are these barriers to care that still, especially for the hardest to reach and the most challenged of patients, people still find it difficult. Pedro, how do you think the vaccine rollout is going in your city, in your country? Can you give us an update on where you're going with the vaccine?
Yes. Well, so far we have started our vaccination program on December 24, Christmas Day. It's ramping up. It's a little bit slowly. So far we have received 5 million units, 5 million syringes, so to speak, in a country that has 45 million people. We aim to vaccinate at least 60% of the population. Now 3 million doses are coming next week, so we will have 7 million. But the main problem is that we have contracts with several providers that wouldn't abide to the contract, wouldn't deliver at the time they have promised to do so. If everything would have worked as they should have worked, well, probably we would have 20 million doses now in the country, and we're barely having 4, and next week it will be 7 million. So we are vaccinating, first of all the healthcare services, healthcare workers, essential workers like firemen, security forces like policemen, etc., and people over 70 years old, and people younger than that with comorbidities. But still, a lot of them are still waiting to be appointed because the number of vaccines that we have is not enough to cover everybody at the same time. We are doing well, but we need to do better in a shorter time frame.
What about in the US? Do you have any thoughts about how it's going?
Yeah, so in the US, President Biden has committed that there will be sufficient numbers of doses for all adults to be vaccinated by May. However, the issue is, getting that vaccine out to the states and getting it into the arms of those individuals. And much like most of our COVID response, states are kind of left up to their own devices to figure out how they want to prioritize vaccine distribution and to which populations. For the most part, it's been older adults, individuals who are, now we're starting to vaccinate teachers in some settings, as well as individuals with comorbid conditions. So, the rollout varies, again, based on state. For example, where I live in Washington, D.C., they have been able to move into their their phase 1, but their third tier within that phase to vaccinate individuals who are 16 and older who have a comorbid condition or a coexisting condition that puts them at higher risk. Whereas in a neighboring county of Montgomery County, they have not been able to expand testing, and they have not been able to get the state to allow them to have a mass vaccination clinic yet to be able to really scale up testing in a county that's 1 million individuals. So it's even larger than population-wise than the number of people living in DC. So it just shows you the continued kind of disparities in how we're responding to the pandemic and how the vaccine rollout is occurring. I'm hopeful that the doses will be here, and that hopefully by fall, most individuals who need to get vaccinated, adults 16 years of age and older, will be able to get a vaccine if it's offered to them.
This is an issue of equity. We know that some countries have bought 9 times the vaccine they need. And other countries in Africa, for instance, didn't have one single dose of vaccine so far. So WHO is calling for more solidarity in this regard and really to make an even redistribution of the available vaccines. I know that is wishful thinking, but I think we need to push in this regard. There is yesterday at CROI I saw they invited us to sign a declaration trying to support the idea of equity in the distribution of vaccines and access for everybody, because we need to be clear. It's not only about being in solidarity with other people. It's in our own interest. If my country is very successful vaccinating people, but the neighboring countries are not, the pandemic will come back. So being selfish and not thinking about other people doesn't pay off.
Oh, absolutely. And, just a within city-state example of this equity issue is in DC, you had to go online and sign up for your vaccine, right? And so individuals who had computers, who had resources, who had smartphones, who had multiple people in the house, ready at 9 o'clock in the morning to pounce and to be able to get that coveted vaccine appointment, were able to do it. And if you looked at the distribution across the city in the areas where it was predominantly older African Americans, they weren't able to get vaccine. And so the city had to just take a step back and say, okay, we're going to have certain priority areas in the city where these individuals can sign up for their vaccinations. And they kind of opened it up gradually over time. But again, it's just another example of these inequities.
Yes, it's interesting. In where I live in Seattle, a week after next, they're going to open one of the football stadiums specifically for minority groups to be vaccinated. So it'll be community-based organizations referring people, trying to address disparities in access to the vaccine. And I think this session's been about service delivery, and it's certainly the case that delivering vaccines to 300 million people in the US and all the people around the world, this is a huge challenge in delivering of services. And I think generally it's going okay. So we all see. Listen, I'm going to close now. I think unless either of you have anything else that you'd like to say, we're just about at the top of the hour. I'd like to thank you both very much for your time and for spending time with us. And I think the discussion's been very interesting. So any last comments from either of you?
Well, Amanda?
Oh, I was going to go ahead, Pedro.
No, please. Ladies first, as I said.
Thank you. No, I just, I do really want to take a moment just to commend all of the healthcare workers out there that have, been working tirelessly for the last year, and unfortunately will continue to work for several more months until we get to a point where, hopefully we'll have herd immunity and things will kind of settle down a little bit with the pandemic. So I wanted to just, thank those individuals, as well as all of the people working in public health who've been able to, help guide our response to the pandemic. And I think that, as HIV providers, researchers, we've seen a lot of this, unfortunately, with HIV, and have been able to be innovative and creative and nimble and resilient in the way that we have been able to make sure that our clients and our populations and communities are cared for. So I'll end on that note.
I would like to second Amanda's comments. I put my signature below. And I would like to really thank IAPAC for giving this opportunity of having 1 hour to stop and think and discuss and learn from my colleagues. So I'm very grateful for this invitation, and I hope that the rest of the activity is as good as this one was. So thank you again.
Amanda, Pedro, thank you very much again. I really appreciate it, and take care. Stay safe. Bye.
Bye-bye.
Bye.